Hello, my name is Michael, and today I'll be talking about Otalgia, and this is part of the ENT series of the surgical curriculum on 10-minute medicine. The learning objectives would be to recall the primary and secondary causes of Otalgia, and to be able to recognize the key elements of the history and examination to help you differentiate between these causes. We also go through otitis externa, otitis media, and learn about the clinical presentation, management, and also the ability to recognize the red flag signs of the complications of both of these conditions. So here I want you to just pause the video and think of 3 causes of Otalgia. So in terms of causes, I like to split causes into primary and secondary causes of Otalgia. The primary cause of Otalgia means that the pathology is coming from the ear itself. However, secondary means that it's coming or referred from different structures sort of close to the ear instead. So many primary causes of Otalgia are infection related. So you have otitis externa and otitis media, meaning inflammation of the external auditory canal or the outer ear, or otitis media as the middle ear infection. You have mastoiditis as a complication of otitis media, and also Ramsay-Hunt syndrome, which we'll come on to later. You can have traumatic causes, which will give you an acute otalgia, and you can also have sort of foreign bodies in the ear or impacted earwax as well. You can have more rarely cancers of the ear as well, which can cause pain. Now, secondary causes of otalgia tend to be more chronic and happen over a longer course. So you have dental infections or dental causes of referred otalgia. You have TMJ disorder or temporomandibular joint pain, which also comes with sort of clicking of the joints of the TMJ when you're eating in particular. And you can also have head and neck cancers, which can lead to referred pain to the ear. And so, with every history, you want to cover Socrates when talking about pain. In particular, about ear pain, there's a large differential, so it is useful to go through this. You may want to ask about the history of trauma to the ear or foreign bodies in the ears, and you can also go through different related otological symptoms. So, otorrhea or discharge from the ear could point towards a infection. You can have sort of ringing in the ears or tinnitus, hearing loss, or vertigo, which means sort of spinning, feeling like the room is spinning around you. You may also want to go through upper aerodigestive tract red flag symptoms. So, for example, having difficulty swallowing, changes in your voice as well, and weight loss or appetite loss may all indicate potentially a head and neck cancer leading to referred ear pain. So here I have a few images for sort of spot diagnoses. I just want you to pause the video and see if you can identify what's going on in each of these images. So on the top left, you have inflamed and dry skin, and in the external auditory canal, you can definitely see sort of white, yellowish exudate, as well as an inflamed and swollen external auditory canal. And this could indicate something like otitis externa and maybe a bacterial cause, purely based on its looks. However, you'd want to do a swab as well. Okay, on the top right, you can also see a sort of a red bulging tympanic membrane, and that could indicate an otitis media, an acute otitis media. On the bottom left, you can see that there is a vesicular rash on the outer ear, and probably you'll see that in the external auditory canal as well if you were to look inside. And with that, you can see a facial nerve palsy affecting the right side as well, which should be non-forehead sparing, indicating a lower motor neuron lesion, which would be the varicella zoster infection in Ramsay-Hunt syndrome. And in the bottom right, you can see the external auditory canal with a metallic object in it, which is a foreign object which needs to be removed as soon as possible and needs referral to A&E. So I've got a case here, and then you're the ENTSHO receiving a GP referral over the phone, and this is quite a common thing that you might be sort of encounter as an ENT SHO. So you have Mr. Smith, who's a 45-year-old man. He's returning from a beach holiday in Spain. He's had a 5-day history of ear pain, not severe, and he finds it's worse when he cleans his ears every day with a cotton swab. He has noticed some clear odorless fluid draining from his affected ear recently, and he's been able to sleep well despite the ear pain. The only relevant sort of past medical history is he's a type 2 diabetic and he's on insulin. So what other information would you like to know over the phone whilst you're speaking to one of our GP colleagues? And what's going through your head as the most likely diagnosis? So these are just a few things that come to mind, really, and I'm sure there's more things you can ask as well. But you'd want to know what treatments they've tried up until now. So have they had any sort of antibiotics, whether that's ear drops or oral antibiotics? Have they had any previous episodes of ear infections in the past, perhaps? Are they, because they're diabetic, they might be at risk of ear infections? How is their diabetes control? If he's on insulin, maybe he has more of a challenging diabetic control. And what's his most recent HbA1c, for example? Is he adherent to his medications? Does he have any previous swabs and any microbiology to help guide treatment? And does he have any other conditions that may lead to immunosuppression? You'd also, of course, want to know his examination findings, as well as his history, which wasn't mentioned in the previous lab, and also his current observations and how he's doing clinically. You'd also want to just go through the red flag signs for any complications of otitis externa. So you find out that he has trialed 7 days of oral amoxicillin, and he's had a previous ear swab sort of 7 days ago for Pseudomonas and Staph aureus infection, which is very common in otitis externa. He's not had any previous ear infections, but he's got suboptimally controlled diabetes. His HbA1c is 55. He's apyrexial, he's clinically well, he has no signs of any other complications, it seems. And in examination of his right ear, he's got tragal tenderness. His external auditory canal is erythematous and mildly swollen, and has a sort of a creamy custard-like discharge, as you can see on the right. His tympanic membrane is pearly grey and translucent, which means it's completely normal, and his left ear is also normal as well. So how would you manage this patient? So it seems like this patient has otitis externa, and it's not been quite optimally managed yet. He's had some oral antibiotics, but actually those are largely ineffective in treating otitis externa, and antibiotic ear drops are the mainstay. So it would be a good idea to try this for 2 weeks, and then the GP can reassess this, and if it's still not resolving after 2 weeks, then it may require a re-referral to the ENT SHO and maybe to be seen in the emergency clinic if it's not resolved. The antibiotics largely depend on local microbiology guidelines. My trusted ciprofloxacin dexamethasone, which is a combination of antibiotics and steroids as well. Give some analgesia, you can recommend that, and importantly, dry ear proportions, so not going swimming, keeping your ear dry during showers if you can, and not to use any more sort of cotton buds in the time that this patient is recovering from this infection. You'd also want to safety net the patient for any complications of otitis externa, and ultimately want to get on top of his diabetes as well, which is a risk factor for recurrent infections or complications of otitis externa. So what are the potential complications of otitis externa? So you can have complete acute stenosis of the ear canal, which makes it very difficult to treat because the antibiotics essentially cannot get to the points of the external auditory canal where it needs to go. And therefore, this often may need something called a Popewick insertion, which you can see is on the top right. And essentially what that does is it sort of wedges open the external auditory canal and allows ear drops to enter past the area of stenosis. And this might require sort of referral onto ENT. You can also get spreading infection leading to pinna or periauricular cellulitis around the ear, you can see on the right hand side, or you can get a complication called necrotizing otitis externa, and this is particularly seen in those who are immunocompromised or diabetic. This essentially is osteomyelitis of the temporal bone or the skull base, and all of these actually potentially require admission into hospital or at least an ENT review. Necrotizing otitis externa is treated with antibiotics and will need to be confirmed on CT temporal bones. And lastly, you can get formation of abscesses as well in the ear canal. I'm going to very briefly go through acute otitis media, which you can see in the top right. It essentially affects young children, typically under the age of 7. However, adults can also get it, and it's usually a viral cause. Patients can complain of sort of increasing pain in their ear and sometimes without discharge. They may have a preceding upper respiratory tract infection, which can lead to the viral infection of the ear, the middle ear. And clinically, you'll see a red bulging eardrum on otoscopy. Children will not be able to tell you all this history, so they might just appear unwell and may cry, but also pull at their ear as well, and that's where we just need to have a look inside to see if there's any abnormalities on the eardrum. And largely managing acute otitis media is sort of reassurance in most cases, as it takes from about 3 days to a week to resolve. However, you may also want to consider antibiotics if the patient is systemically unwell or has sort of suppurative otitis media, or if they have bilateral otitis media and they're less than 2 years old. Complications of otitis media includes intracranial complications, so meningitis, sigmoid sinus thrombosis, where patients get a fever, a headache, as well as potential meningism signs as well, and can also lead to brain abscesses, where patients can have focal neurology and appear septic. They can also have extracranial complications such as facial nerve palsies, which tend to resolve with resolution of the otitis media. And you can see that there's a way to score the facial nerve palsy on the right side in that table, which is called the House-Brackman scale. The middle ear infection can spread to the mastoid, causing mastoiditis. And you can see in the top right, this child has a boggy swelling erythematous behind the ear, leading to a loss of the postauricular sulcus, as well as pushing forward of the pinna.